Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. The title for our show tonight is The Quality Issue in Cardiology, Part 2. Again, this is part of a series of shows during which I will have the opportunity to interview and to profile the clinical champions in different specialties. And tonight we're talking about cardiology. And of course, again, to define clinical champions, that would be the physicians who, by virtue of their expertise, their knowledge, their experience, and their integrity, are in the position of defining for us what quality services is in their field of expertise. And this is the second part of our series on cardiology, and I'd like to invite our speakers back to share their knowledge and information with us. At the end of our first show, we're talking about patient satisfaction is the third element of the quality medical services. Now, you mentioned to me in a private talk that if you have one patient going to see 7 cardiologists, you have 8 different opinions. I mean, how and all of them are well trained, or all of them know what the standard of cares are. How come? I mean, how does the patient know who's better than who?
Well, I think that in this day and age, patients are very well informed, sophisticated in terms of medical care, and actually, I believe, hungry for knowledge to learn how to deal with their ongoing medical problems and to think about the therapeutic options. Part of our obligation as physicians is to make that information available to them, to provide a balanced perspective in terms of options. For example, in terms of coronary disease, blockages in arteries when patients have angina, whether to pursue medications versus a cardiac catheterization, angioplasty, and bypass surgery.
Yeah. So make them participants instead of purely recipients, right?
I think the times when we can, as physicians, say to our patients, you must have this procedure, are gone. I think that now we must and should inform our patients of the different options, and oftentimes they may not be black and white.
Yeah.
There are a few instances in cardiology where it's clear patients need a bypass operation. On the other hand, whether to have angioplasty for a balloon angioplasty for only one artery blocked, single vessel stenosis, versus medical therapy, I mean, those are oftentimes equivalent therapeutic options.
Now, that's one of the main reasons I produce this show, is that I truly believe that as physicians, we need to learn how to speak plain language, because sometimes it improves the patient rapport, and the educational process is very important in patient satisfaction. Do you think that's part of the training of cardiologists at Stanford?
I think it has to be part of the training of physicians, cardiologists, from the time they go to medical school to the time they go into practice in cardiology. Unfortunately, the nature of their language becomes increasingly complex from the day they start medical school. And with every level that we're asking them to learn more, their level of sophistication, in a sense, increases. And so that's why, at least in cardiology training, rather than pulling people away from patients for 3 or 4 years and saying, let's learn all these specialized techniques, the catheterization techniques, the echocardiographic techniques, and then at the end of 4 years saying, now that you've become an expert at all these techniques, let's throw you back at the patients. And effort is made really to try to maintain the physician contact all through the training, so that they can maintain some bearing, if you will, or some level of communication with the patients, which allows them to sort of continue to change their ability to transmit the knowledge they're learning to the level that patients can understand. And it is actually quite difficult, but the patients really are very good at judging that for themselves. And the important thing is making sure that these fellows, as they're learning, continually have to transmit and educate their patients along the way, so they learn themselves how to do it. And that's not such an easy skill, really. And there are clearly physicians who are better at transmitting information than others. Unfortunately, there are good communicators who aren't necessarily actually good at making decisions. And so
Yeah.
those aren't necessarily the same skills.
Randy, although I'm at Kaiser now, I'm a recent graduate from Stanford, and so I think that Stanford has adequately given me the tools to communicate with patients, and it's very difficult to condense or distill the high-tech information down into what patients can understand, or and different patients want to know more or less about the different tests.
You see, I mean, we have been insulated with publications in scientific journals, but maybe you should be writing, columns like Landers.
Yeah, I mean, I spend about 1/3 of my time while I'm seeing a patient discussing the results of recent cardiac tests and implications for their care.
Yeah.
And so it really is a sizable amount of time.
I think that's
spent.
excellent because, I mean, the main complaint I hear very often is that, I don't understand any doctor's talk. So we really need to improve our ability to communicate with them so they can understand, because they like you said, they're hungry for information, Let's talk about preventive.
Let me just say, too, that I think that there is a time commitment, a pressure nowadays in a lot of the managed care situations where you don't have the luxury of spending a lot of time with the patients. And we made the decision in our own office to ignore some of those guidelines and have a minimum amount of time that we'll spend seeing a patient for a visit and explaining their problem. But I think a lot of people are being pressured to spend very short periods and see a lot more patients per day, and I think that has to be resisted to keep the communications up.
Well, again, communication, the quality of communication is not necessarily the quantity of time. I mean, sometimes you can say something very brief and easy to understand. That's why, that's why I have this show.
Sure.
Right? English is my third language. But I've trained myself to speak pretty well, on this show. So, I mean, if you have doctors who are interested in coming to show, I think television can be extremely helpful. You can instantly have the feedback of what you're talking about, and you can show to your wife, you can show to your, people, your patients, and see if they understand what you're talking about. But that's why television is so powerful.
But the responsibility for this information flow doesn't necessarily have to be all through the physician. We have found, and a lot of people have found, that patients actually respond equally well to nurses, nurse educators, other healthcare professionals who sometimes don't have the same time pressure, sometimes actually speak in a more common vocabulary, or somehow are better able to express in a layman's term these problems, and often don't carry with them the same emotional baggage that patients have towards their physicians, where they're afraid to sound stupid or sound critical or whatever. So I think that there has been an awful lot of progress made in successful patient education from the non-physician, and patients neither seem dissatisfied nor are they getting inadequate support from them.
But don't you think the physician's truly part of it? Would be part of
Absolutely.
the teaching force,
And
educators?
It's the physician's responsibility to make sure that the kind of information that is being put out or disseminated, even by the non-physicians, is, according to the, what they think is
Because
appropriate.
one of the main problems of the crisis we're having right now is that we're seeing our control of medical care taken away from us more and more. We are more isolated, So I think that's more important, that we take a step forward to change our style, and our practice even, because otherwise we'd be like technicians. We think of us as, sophisticated plumbers instead of, because, let's talk about preventive medicine now. Are you familiar with this book, Reversing Heart Disease? Can you zoom in a little bit here? In preparation for this show, I came across this book, and I really enjoyed it a lot. This is really a great book. It's called Dr. Dean Ornish Program for Reversing Heart Disease. And just for a sampling starter, let me challenge you with this paragraph here on page 27. Last year, over $7 billion was spent on bypass surgery in this country. If I perform bypass surgery on a patient, the insurance company will pay at least $30,000. If I perform a balloon angioplasty on a patient, the insurance company will pay at least $7,500. If I spend the same amount of time teaching a heart patient about nutrition and stress management techniques, the insurance company will pay no more than $150. If I spend that time teaching a well person how to stay healthy, the insurance company will not pay at all. It's not surprising that doctors tend to spend time on what is reimbursed, especially since we do not learn much in medical school about nutrition or how to motivate patients to change their lifestyles. We are not taught skills of coping with stress in our own lives or for teaching these skills to our patients. So, we doctors practice medicine in ways that we're trained to do and in ways that we're paid to do. That's pretty damning. What do you think?
I would say that that is the absolute pessimist, cynic, and critic's view of the practice of medicine. And I think that, unfortunately, we are all paying for that perspective, that physicians are operating purely on the basis of economic motivation. And I think that I suspect that there are physicians who clearly are guilty of that, or some aspect of their care can be characterized in that light. The danger of statements like that are suggesting that these are all mutually exclusive approaches. That we were talking about that just a few minutes ago, that the patient either gets a bypass operation or gets a discussion of the correct diet and the correct risk factor management, when in fact, potentially both approaches need to be overlapped and performed simultaneously, and that it wouldn't be worth doing a bypass operation on a person who does not have the commitment and interest in manipulating their risk factors so they could even benefit from that. So,
that's why you're here. I wish that some of you can be on, NBC or CBS saying the same thing, because this is being read by millions of people around the world, and it gives us a bad image, And also the National Program Dateline reported that up to 300,000 angioplasties may not be necessary, but are performed anyway every year.
Although, Dr. Gu, I think
really terrible.
Kaiser is in a unique position in the fact that as physicians, we don't get reimbursed based upon the number of procedures we do.
Okay.
And in fact, I think that we have over the years used so-called physician extenders or educators very effectively. I am director of the cardiac rehabilitation program at Kaiser Santa Clara, and so we have an ongoing set of classes, 6 classes, called the Change of Heart classes, 2 hours each Monday night for 6 weeks. That's 12 hours per session, talking about what you've just mentioned. Nutrition, stress, exercise, how the heart works in medications, the role of cholesterol, and all the different tests that we have available as cardiologists to them. So that you can turn the tables around and focus on prevention and reach a greater number of patients who are at risk for having heart disease later in the future.
I just wanted to add to that, because I think that what both of my colleagues have said is absolutely true. I think that the practice of medicine is not mutually exclusive, as it's stated there. We all have programs to teach patients prevention, to reduce risk factors, as well as to treat problems when they've gone beyond a certain point and require intervention. So
don't you think there should be more incentive in doing that? I mean, you don't pay anything for us to do that. I mean, you can be at Kaiser and you have a salary, that's okay, but you in private practice and you teach a patient in a couple of hours, you don't get any pay. I mean, that's pretty
well, but I don't think that, again, I agree with Dr. Vangelos. I don't think that our motivation is just the reimbursement level for a service rendered. So, I mean, we don't all go around doing.
But I think that he talks about a system, though, a system of inequity and inefficient way of doing things, because we don't.
Well, but again, I don't think he approaches the problem. I mean, if you were going to say you were going to reimburse people for teaching dietary modification and risk factor reduction at the same level that you were reimbursing them for interventional procedures, the cost of medical care would skyrocket. I mean, it's not possible to pay for that kind of service that way. And as Randy said, there are physician extenders who do some of that. But I think our approach is always one in which the patient has to take responsibility for changing their lifestyle and living a healthy life. So.
Might I say that I think Dean Ornish in his book is trying to make an important point in that we should not ignore the aspects of diet and exercise and stress management that he talks about. Although I think that as a group of cardiologists, we agree that that should be part of a multifaceted approach for taking care of patients, and that we do incorporate that in terms of what part of what we do, but we cannot ignore the other things that we have available
Yeah.
for patients,
Right.
whether it be bypass surgery or medications or balloon angioplasty.
Yeah.
There-
I think the strength of his book is that he combines science with what he called the psychological or the spiritual heart, which to me is very romantic sound to it. And I agree with him, because coming from my background, I think that those
Yeah.
things are very important. As you probably know, a lot of arrhythmias are psychologically determined. That's why you cannot treat so well with,
Well, it's hard to
medicines
separate
and-
panic attacks, anxiety attacks from
Exactly.
real significant
Exactly.
arrhythmias.
But I think this is, anything that focuses some of the responsibility back to the patient is empowering to patients, and they like that. I mean, they like to know that this is not a situation in which their only hope is what the physician does for them, or what the medication does for them, things they can't understand. And that is an attraction. And I think that in my own experience, the patients who are most, I won't say vulnerable, but most attracted to an intervention like this are the people who desperately want some control over their future and absolutely
And
hate.
fairly so.
Yes, and absolutely hate a situation or uncomfortable in a situation in which they are prescribed or ascribed or dictated to in every way that's going to outline their future. And this isn't just his aspect of things. You can get into the treatment of heart failure, where allowing a patient to dictate how much sodium they're going to take and how much fluid they're going to take, and manipulating their medications is very attractive to patients in terms of really gaining back some control over the process. So I think that's part of the success of this book and this physician's approach is to try to educate enough that patients feel like that they're not completely at the
Yeah.
at
I have
the
to say
limit of
this,
physicians.
to his credit, I have adopted his diet, the reversal diet, and I think it's great. I mean, I feel very good about it. I have very few risk factors, but I think it's. I really have to say that it's. I mean, we have that kind of diet for thousands of years. The so-called vegetarian diet. But I mean, we as a society, I mean, just overeat the wrong thing, and that's a very big
Well,
part.
I think a lot of the responsibility has to go back to patients.
Right.
Yeah.
And I think that the Dean Ornish program is a good one if you can afford it. I mean, what Kaiser has done is to make it available to patients, to a large number of patients at Kaiser,
Yeah.
at a cost that is nominal
Sure.
compared to the
Absolutely.
thousands of dollars that Dr. Dean Ornish would like you to pay for the
Yeah.
program.
It cost me $7. It didn't cost me, all the money that.
Well,
I
I mean, it
pay.
may come to a time where we as a society decide that we're not going to want to pay for certain lifestyles. And we haven't come to the point where we've said that people who smoke, ought to have a
Sure,
different cost of
absolutely.
insurance. And
Right.
people who eat cheeseburgers, every night for dinner ought to have a different kind of insurance. But, as compelling data keeps being generated over the years, that certain lifestyles are likely to, commit some patients to certain endpoints,
Sure.
clinical problems. It may get to the point that those people who are willing to change their lifestyle are unwilling to support economically the people who are not.
Sure.
I mean, that brings up two very important points. I mean, personal responsibility for your own health is a very important thing, and,
Sure,
and
absolutely.
empowerment of the patient, as Dr. Lee pointed out too, to help make decisions is a very important thing that we all try to bring in practice. So I think his focus on that is good. But if you're going to take the power to make a change, you also take the responsibility that if you have an unhealthy lifestyle, there should be some consequences for that. So I would agree, maybe a differential insurance premium for people who choose to live an unhealthy lifestyle.
Now, my
Well, Dr.
understand-
Vu, your point is well taken in a sense that prevention, will always be more effective in preventing illness
Sure.
than dealing with the problem later on after it has manifested itself.
The end product of the process.
Of course, but you have to deal with both. We
Oh,
have a certain-
correct.
we have a segment of the-
You cannot ignore one
Right.
and be blinded to the other.
When you have patients who have a problem that's already reached the point where you have to do an intervention, I think it's unfair to say because you could have prevented it by a healthy lifestyle, that those treatments are unnecessary. I mean, I think that's getting...
Well,
a little
it's
bit-
very timely to talk about this because, as you probably know, the main problem of the crisis is really economic. If we continue to practice the way we do now, we will double our expenditure in 30 years. Right now, we're already spending 14% of the gross domestic product. And if we continue to do the same way we're doing, in 30 years, it will be 30%. You spend 1/3 of the gross domestic product in healthcare. And that's
and that's
unreal.
why Kaiser has just come out with a long series of preventive guidelines, for
Excellent.
all the
Excellent.
the medical centers, Kaiser medical centers in Northern California, to work on all of these things: hypertension, cholesterol screening, immunizations, and so on, smoking cessation.
Yeah. And in a sense, it's a threat to our profession, because you have been trained to do certain things, And now if landers, if a nurse can go and teach, then we'll be out of a job. It's really something we have to think about very seriously, because I think that I am an optimist. I believe that there's enough money for everybody, if we do it right, and if we continue, right now we're in a true crisis, like some CEO is making 1.2 billion, and hundreds of doctors and nurses are out of a job. That's why the main purpose of this kind of show is to really, for us to have the opportunity to talk to the public, so we're not isolated behind, our scientific journals anymore.
I think we have to be very careful, too, about what vehicle we want to use to make medicine more cost-effective, because I'm not sure that there's going to be true money saved in some of the managed care systems. The money will be diverted into different
Exactly.
costs,
Redistribute.
bureaucratic costs, administrative
Yes.
costs. I'm not sure it's going to be saved to be put into the system to make the system better, and there are critical parts of medical care that I think should be funded, and then there are less critical programs that I don't think are quite as important. So we have to have a system of priorities for what we think we
I
want
think
to
that
treat.
point is well taken, because I truly believe that it's okay to cut waste,
Right.
but you don't use the money saved to give to individuals and financial interest groups. You should refund it to the you give rebates, whatever, to the
Or put it in,
public.
you have to do something to fund research and development
Yeah.
too, and some of this is not really thought of in some of these systems. You see.
Because right now, people are just out there for the blood, they just, get more and more money into their hands, and everyone's take control. And it's very dangerous. And I believe that as a group, we physicians have to be more outspoken. We have to get together. We are the providers. We should be able to define our product and go to the public one way or the other. We complain about the intermediaries, but we have to effectively get together and define our product. And the main problem is that, like you said, during these shows, I have the opportunity to learn about how to define quality. And this is the first time you have cost effectiveness and patient satisfaction. It was very muddy before. That's why we need to have that kind of...
Well, I think that the other attractive aspect of the last few years is that almost any intervention is now also being measured from a cost-effective
Sure.
aspect as well. And society demands it now. If you are going to prove putting a metal tube in a coronary artery is better than putting a balloon in an artery, not only do you have to show that the patient has fewer symptoms or fewer follow-up procedures, but people want to see that the procedure over time will save the patient and the institution less money, and over the length of the patient's life be more cost effective. People want to see that information.
Right. Actually, another point that I really admire Dr. Onishima is that he does have depth, in his explanation of things, in that we're talking about diet, but it's not the diet. It's what kind of behavior there is, why people eat certain things, and you have to really know how the deep subconscious reason for that. Otherwise, you cannot help them. You can talk about intellectually, everybody knows that, we should eat 75% carbohydrate and all that.
Well,
But it's very difficult to do it.
I remember that in reading his book, too, that he had an interesting story. He thought it was very clear to a lot of the patients that he had in his program that they were better off following what he said. They were healthier, their symptoms went away, they had less angina, they just felt better, as you pointed out. And yet some of them didn't change their lifestyle. Some of them continued to smoke and eat the wrong food, and he just was very frustrated. And he asked this group that were unwilling to change, why don't you do what I'm telling you? Because it's clear that you'll be better off and be healthy. And they told him that their interest was that they wanted to keep their habits because they enjoyed them. And it made their day more pleasurable to smoke a pack of cigarettes or to have the food they wanted. And that was more important than the long-term outcome. And unfortunately, sometimes we make decisions that way.
Well, we have a role as educators, to let patients know about how changes in lifestyle and behavior will affect their lives 10, 15, 20 years down the road in terms of stopping smoking and so on, exercising and so on.
But you see, that's a very basic philosophical question you're talking about, because if we do things for pleasures to be destructive, then you have a big price to pay. And it really is a society, you have to spend some amount of money in education and even motivating people to do the right thing, because in essence we are subsidizing the people with bad habits. And I don't think that's right either. Like the people, all of us have to pay premium into a pool, and it's no longer compassionate to support that kind of lifestyle. You see, because it perpetuates their misery. You see, so you want to say something, Vangelos?
No, I'm happy to say something, but
you're agreeing with that.
I am agreeing. I think that it would be dispassionate at this point to start ascribing, a set set to all the people in your community.
Yeah. But you give that as an option.
But I think that, the fact is that you potentially could smoke cigarettes for the rest of your long life, and be one of, all of these things are statistical, biases.
I'm sorry, you were running out of time. I'm sorry, I have to.
That's okay.
Sorry. Anyway, this is Dr. Vu. We just finished the second part of the quality issue in cardiology, and I'm very grateful to have with me here three marvelous cardiologists to share their knowledge with us, and this hopefully will bring some useful information to our viewers. And this is again America's Healthcare Crisis. I'm Dr. Hung Vu. Thank you for watching. So long. Good night.
Someone, have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near?